Okay, so let's hang tight and now turn our focus to pharmacodynamics, which, as we talked about, is how the drug's concentration relates to its clinical and hopefully therapeutic effect, not the toxic ones. So, the two key variables that we talked about before that we want to revisit again to bring it all together is the maximum effect, which we know is Emax, and sensitivity, which is your EC50. So the maximum effect Emax, every drug is going to have a maximum achievable effect. That's the ceiling effect. This is a point beyond which increasing the dose won't give you more benefit. So we know that is the Emax. So if a patient with a heart failure is on a maximum dose of furosemide and their shortness of breath doesn't improve, it's possible that they've hit their Emax. And so giving more, unfortunately, won't help. But giving more would increase the risk of ototoxicity or electrolyte loss. This is that toxic effect. And so you can see why this concept is important clinically, because we often see ineffective dose increases, especially in outpatient settings where prescribers try to push for effect by increasing the dose and not realizing that the therapeutic ceiling has already been reached. And the sensitivity, the EC50, this is about how responsive a target organ is to a drug. So remember we talked about this being EC50, which is the concentration that produces half of the drug's maximum effect. So we know that the lower EC50, meaning the graph and the curve is shifted to the right, then you're looking at more potent drug effect. But of course, if the patient isn't responding despite achieving this normal therapeutic drug level, then it may be the case that they have reduced sensitivity. So an example of that is in hyperkalemia, where you have too much potassium, the heart is less responsive to digoxin, and that because it's less responsive to the drug, because of underlying condition hyperkalemia, you're going to need to provide higher levels of the drug to achieve the same effect of the EC50. Now, if the patient is on a calcium channel blocker, it can antagonize the digoxin's inotropic action, so it blunts the expected response. So on the flip side though, if this patient shows a strong effect from a lower dose, it may then indicate that there's an increased sensitivity. So if the EC50 is showing up at a lower concentration than what you would expect in an average population, then what you're seeing could be an increased sensitivity. So a classic example of that is elderly patient developing bradycardia, which is slow heartbeat, or hypotension, low blood pressure, even after a very small dose of beta blocker or benzodiazepine. So by measuring the drug concentration, we can actually distinguish, is it a pharmacokinetic issue or is it a pharmacodynamic issue? So if the concentration is low and you see a high effect, then you can suspect increased sensitivity. If the concentration is high, yet the effect that we are seeing is lower than expected, then you can suspect reduced sensitivity. And so this is why seeing your EC50 matters and where to benchmark it, and so you know which one is the outlier. So we apply this thinking regularly in hospitals when you're adjusting for a whole host of drugs, especially with patients that have electrolyte disturbances, that have polypharmacy, that have age-related pharmacodynamic changes. So when we interpret drug concentration measurements, the first thing to remember is clearance. Clearance is the king. It's the most important determinant and the go-to suspect in determining how much drug remains or would remain in the system. But we also need to be careful because the number on the lab report for the total drug concentration, it, of course, as we talked about, it does not tell us the whole story. So again, let's bring it all together by walking through the key considerations that would affect how we interpret the drug levels. So, clearance and its influencers. So drug concentration is going to be an interaction that's shaped by the dose, the organ's blood flow, because if there's no blood flow, you're not getting in there, right? And of course, the functional capacity of the liver and the kidney. So in renal failure, the clearance of the drugs like vancomycin would be reduced, meaning that your drug level staying in your system would rise. In hepatic dysfunction, clearance of morphine may decrease, as an example, because your liver is not breaking them down as it normally would. But it's also not always the case because clearance in hepatic function can also depend on not just the overall hepatic function, but intrinsic enzyme function that's within the liver, which can stay active and intact despite the hepatic disease. So it's not always the case either. And then we have protein binding that can mislead us in terms of the total concentration. Protein binding can falsely suggest there's a change in clearance if we rely only on the total drug levels. So as in the case with low albumin, which is a blood protein, and it's common in liver disease or cancer or other critical illness, where you see this low blood albumin level, it means lower total levels for albumin-bound drugs like phenytoin, but the active unbound concentration may be normal. Now, in contrast, the alpha-1 acid glycoprotein increases during inflammation, raising the total level of drugs like propranolol or quinidine, even though their pharmacodynamic effect may be unchanged. And some drugs, like prednisone, have the concept that we talked about, which is saturable binding. And this, at high doses, if you have saturable binding, the protein binding would max out at some point, and the more drug would stay unbound. And so in this case, the total concentration appears to increase less than expected with the increasing dose, but the unbound active drug still increases proportionately. And so these are the things that layers upon layers of it that needs to be considered. And there's one more, what we call the red blood cell binding. So drugs like cyclosporin bind heavily to the red blood cells themselves. So we measure the whole blood concentration. If a patient has low hematocrit, then the total measured level would drop even though the free drug concentration might not change. So in BC transplant units, the dosing decision for tacrolimus often would include correcting for this hematocrit binding piece, and especially for those patients that are on dialysis or they're post-chemotherapy. So all this is to say, you have to always ask, does the number reflect the free active drug? And we can't overreact to a low or high total drug level until you've considered protein binding, clearance, red blood cell hematocrit level, as well as the dosing rate. Lot to think about. Now, one of the most common but underappreciated reasons for misinterpreting drug concentration is the missing or inaccurate dosing history. So, this is the human error piece. When we measure a drug level, that number is only useful if we know for a fact that the drug was when the last drug was taken and how it was dosed. So without this, the measurement is like taking a blood pressure reading with no idea whether the patient was resting or running or was in the middle of a surgery. So here the context really is everything. I mean, if the patient was running and they're completely out of breath and you're taking blood pressure, you wouldn't be too concerned if it's spiking high, right? So really measuring and interpreting a drug level has to be founded upon an assumption that is proven on the case of when was that last drug dose and how was it dosed, and did the patient or the practitioner administer it correctly. And of course, timing matters. A blood sample that's taken during drug absorption will give us highly variable, and really unreliable value, because the drug absorption is taking place right now. It hasn't fully got to the delivered level. So the absorption generally completes in about a couple hours if it's post-oral dose. But it's affected by, was there food in the stomach at the same time? What was the posture? Were you lying down even or standing up? And activity too, which can dial up or down your overall metabolic rate in the body. So measuring a peak too early can mislead the clinicians, leading to incorrect dose changes. And different drugs have different timing protocols on top. Like digoxin, it's known to distribute slowly into the tissues. So if you sample too early, as in 2 hours post dose, it will give you falsely high levels. So for this drug, we need to wait like 6 or more hours. Lithium, on the other hand, has a standard 24-hour dosing cycle. So if we check levels just before the next dose, you're measuring when it's on the low. And aminoglycosides, even though they distribute fairly quickly, it still requires 1 hour post dose before the blood is drawn. So you can see here, even when we sample for testing to verify how we are doing in terms of reaching and maintaining that steady state, even when and how we assess really, really matters. And there's another whole science and an art to that. So the steady state sampling is when we want to estimate clearance or check if dosing is correct at steady state. So this really means that we have to have a well-timed sample. For most cases, the steady state is reached 3 to 5 half-lives of consistent dosing. Remember that 4 to 5 half-lives concept that we talked about earlier. So the best time to sample is around midpoint of the dosing interval and not at the peak or not at the low. Remember that average desired target concentration, and that would better reflect the mean steady state concentration, especially with intermittent dosing, which would correlate to that average drug exposure over time. So a patient dose might not be perfect, but if the sample was taken at the wrong time or the right time, we might be mistakenly or accurately changing therapy. And of course, depending on which way we go, we might be making a mistake that could even cause harm. Now, there's a bit of a myth buster. Many clinicians assume that the low levels are a better reflection of the drug's lowest and the safest point. But of course, the lows that are taken before the steady state or during the absorption tells us very little about clearance or about drug efficacy. And so that's why trying to get to that midpoint is the sweet spot, so to speak. Okay, let's dive into how we initially predict the volume of distribution and clearance. So just adding another layer, right? Building on from the foundation of what we already know about volume of distribution and clearance. And because this will help us individualize that drug dosing. So starting with the volume of distribution again, remember, this is how widely a drug spreads into the body tissue. So to calculate it, we usually start with the patient's body weight, the obvious. So there is a standard table that's established that would assume, based on a 70 kilogram adult, but of course, this rarely accurately depict a real life setting. We have everybody from a 40 kilograms to 120 kilograms, grossly deviated from the 70 kilogram benchmark, so to speak. So in heavier patients, we can't simply use the total body weight either, because their weight proportion may be from that much more fatty tissue. And remember, drugs like gentamicin, digoxin, they're lipophobic. So they won't necessarily penetrate and distribute into the fatty tissue. So if we use full body weight, then we end up overestimating the volume of distribution, when in fact, the compartment that these drugs will stay distributing it doesn't include these fatty tissues. And so we end up risking underdosing. And so instead, we need to use fat-free mass, the FFM, which better reflects the lean tissue where the drug will distribute into. So this is what we routinely apply, especially when we're dosing lipophobic drugs like gentamicin for patients that are in ICU. Now, on the other hand, though, let's consider patients who have fluid overload because of water retention from conditions that they are struggling with or other medications that cause this. So those with pleural effusion or generalized edema in their body or ascites, these patients have an expanded extracellular space that's water-filled. So unlike the other case with more obese patients, we have hydrophilic drugs like gentamicin that can actually distribute and accumulate in that space. So for those cases, we have to subtract the estimated weight of the excess fluid and use this dry weight to calculate the normal volume of distribution. And then we actually need to add 1 liter for every kilogram of that excess fluid, which is calculated differently than the lean body tissue like muscles. So we actually have to separate that out and then measure that at 1 liter for every kilograms separately from the rest of your body tissue. So there's a correction method that will help us, again, preventing underdosing. And this is more critical for those patients that are in intensive care units. And yeah, so it's not easy, you guys. And clearance then. So clearance, especially renal clearance. Remember, drugs that you pee out by excretion. This is, remember, major driver of dosing decision. And we estimated as we talked about before, using creatinine, which is a marker that we can follow to determine what this rate of renal clearance is. And it reflects glomerular filtration. For those of you that's done anatomy and physiology and looked at kidney functions, you'll be familiar with the glomerular filtration rate concept. Now, creatinine clearance is typically calculated from serum creatinine, which is how much creatinine there is in the blood. And again, we have to adjust it for age, sex, and weight. And there is a formula that helps us do this, and it's called Cockcroft-Gault equation. We're not going to get into that. But the idea is that women produce less creatinine due to the fact that we generally have lower muscle mass than our male counterpart. And so we use 85% of the male value. And of course, as people age, they tend to lose nephrons. These are your kidney cells, not just muscle. And so the serum creatinine may look normal because when you have less, but because you're also filtering out and excreting less because of your reduced kidney function, even if your creatinine clearance is falling, it may not present that way. You have less and you're excreting less, so to speak. And so, again, that's why creatinine clearance is better than serum creatinine alone, especially in older adults, especially because it can present normally, but it may be actually hiding renal impairment. And as the same with the volume of distribution, for the heavier patients, we use FFM instead of the total body weight so that we can avoid overestimating clearance. And for those that are really sick then you the creatinine-based estimates, it may overestimate the renal function, and so you need to take into account that the muscle wasting reduces creatinine production, and that's where it might stem from for that lowered amount. Yes, I hope you're following this. Okay, now let's get into our last slide here. So now that we've discussed how to estimate volume of distribution and clearance, all the considerations and circumstances that we need to account for, let's explore how to revise those estimates based on what we observe in the clinic. So we often make initial predictions using population data, the benchmarks, the average clearance, the standard volumes. But individual patients vary so much. So we compare what we expect to see versus what we actually measure. So step one is we compare what we predicted with what we measured. If the measured concentration is off by more than 20% from what we expected, it's time for us to recalculate the volume of distribution and or clearance using pharmacokinetic equations. So remember that mark. We draw the line somewhere, and that's a 20% deviation point. So if the revised clearance or VD is more than 100% higher or 50% lower, then we have to double check the assumption. So this is what prompts clinicians to kind of go, something is off. And so was the blood sample taken at the right time? Was the dosing history accurate with the patient compliance or the rate of the administration or the route? Has the patient reached a steady state? These are all the questions that one would be thinking about when there is this kind of a large discrepancy. So a clinical example that we can use is, let's say that a patient is taking 0.25 milligram per day of digoxin, and you expect the level around 1 nanogram per mil to be achieved based on 70% bioavailability, and let's say every hour 7 liters would be cleared, like total clearance. But if this patient has heart failure, the heart failure would reduce hepatic clearance due to congestion with blood pooling in the liver, and hypoxia, meaning not enough oxygen going to liver because heart is not able to circulate oxygen. Then what this means is we predict that clearance might be, say, 5.5 liters per hour instead of 7 liters per hour. And then we can expect the concentration to then become 1.3, say, nanograms to be sticking around in your system because you're not clearing like you used to. Because if you did, we'll be at around 1 nanogram. So when your hepatic clearance is impacted, say in a case of heart failure, then you would expect accumulation to begin. So your concentration of the drug in your system would go up. But if you find that what you measured is in fact 2 nanograms per mil, higher than the 1.3 that you predicted, then what you're seeing is that the implied clearance is even lower than what you had expected. So it may be like 3.5 liters per hour as opposed to 5.5 liters per hour. So remember, if 7 liters per hour was the norm, and you thought the heart failure would impact and make it 5.5, and based on that lowered blood flow, you assumed then the drug clearance would be decreased to the point that your drug concentration in the blood would increase to 1.3. That's what you expected. But if what you measured is 2, then it gets you to think, wow, the clearance must be even lower than what I had expected, maybe 3.5, which would get us to 2 nanograms per mil of the drug still kicking around in your system and not getting eliminated. So what do we do then is common sense dosing. At this point, what we need to do is, if 1 nanogram is what we wanted to do, and you're seeing 2 nanogram is what you're measuring, you need to half the dose to get the concentration back near to the 1 nanogram, which is the expected target mark. So this kind of bedside logic is useful, but that's only if the patient reached a steady state, of course. And steady state is a whole other thing. We talked about at least 4 to 5 half-lives, and that would be about 1 week of stable dosing. And of course, if the steady state hasn't been reached, then any conclusions based on one level could be misleading. And so this is where we need to continue using the PK tools for precision. So rather than relying only on mental math, a lot of the clinicians in BC Canada now use things like nextdose.org or other types of similar clinical decision support tools that helps us with this Bayesian modeling. And so these tools can help integrate population data, help you specify individual patient values, enter concentration measurements, and these tools will help the clinician work towards precision dosing recommendation. And of course, the idea is you can't just enter in these values and then just take whatever it spits out and apply it to the patient. You really have to be able to think critically and go, I'm using this tool to help me here, but don't hand it off entirely to these tools. And so it's a balance of being able to utilize tools to help you, but on the other hand, you need to be entirely accountable to the decisions that you're making. So this is a standard use that we have tools coupled with expert decision making to review and apply and to question and to pivot. That's a standard practice that we are looking at, and especially in high stakes area like transplant units, in ICUs, emergency setting, cancer clinics, so on and so forth. So the bottom line here, you guys, is that the revised pharmacokinetic estimates let us personalize care. No one patient is the same, and even the same patient will not be the same yesterday, today, and into the future. And this is an ongoing, iterative, rigorous exercise to avoid toxicity and to really ensure that the drug works as intended. A lot of mental gymnastics, a lot of calculations, and a lot of high stakes. And this is a high pressure type of work.